of my talk is Early Life Exposures, Why Pregnancy Matters for Later Life Health Outcomes. So the objectives of my talk are twofold. The first is to demonstrate how socioeconomic, demographic, medical, behavioral, and environmental factors correlate with disparities in adverse birth outcomes. And birth outcomes could include things, for example, like preterm birth, low birth weight, small for gestational age, large for gestational age, macrosomia, things like that. And the second objective is to show how early life exposures in utero matter for the reproduction of adult disease. And that includes things like cardiovascular disease, hypertension, type 2 diabetes, as well as obesity. And social determinants of health is a broad topic that encompasses many factors, such as the impact of education or income, factors like healthcare and where you live and the type of healthcare provided, where you live in terms of your neighborhood and environment, as well as social and community context. So I'm going to basically tell a story throughout this presentation. The first part of the story is going to take you back to 2012. The person on the right, some of you may know him, is Dr. Bill Avison, who is my former PhD supervisor, and he's retired now. Unfortunately, a diehard Montreal Canadiens fan. We go back and forth and fighting debates on email about the Leafs and the Habs. But he was a really good mentor for me. Back in 2012, just prior to me finishing my PhD, I published a paper with him titled Socioeconomic Status and Cumulative Disadvantage Processes Across the Life Course. And this really spurred my passion, if you would, for looking at the impact of long-term disadvantage and how, being born, for example, into poverty can have long-term life implications across the life course. And a huge part of the life course perspective, there's really underlying principles. And one principle is the idea of long-term temporal patterns. And really, it's the idea that to understand where we are today, it's important to understand one's past, ideally the distant past. So to understand what's going on in terms of our life now and our health, we need to go back earlier in one's life. Okay, so the earlier we can study people across the life course, the more we're going to know about the context of what occurred across the life course and how it has effects on health. So health disparities in adulthood are very much linked to early life exposures. But at the same time, we have to be careful not to be too deterministic. Okay, just because someone is born, preterm or small doesn't necessarily always translate into a poor adult disease, for example, when they're older. The reality is that health outcomes in adulthood are very much products of complex interactions of cultural, historical, demographic, and genetic influences. So, where you're born and when you were born matters a lot for health. Just like one's genetic makeup matters a lot for health. The reality is this health disparities are very much multifactorial in terms of what predicts given outcomes in adulthood. Another important principle, if you would, of the life course perspective is the idea of linked lives. And simply put, it means that what happens in my life is going to impact people in my life that are close to me. Just like if something happens to someone close to me in their life, it's going to impact me. So to keep this within the kind of pregnancy perspective, we know, for example, that untreated prenatal depression is associated with offspring child mental health problems. And that includes externalizing and internalizing problems. A lot of people don't know the difference. So externalizing problems would be things like physical aggression, people who are involved in destruction of property or disobeying rules. Whereas internalizing is kind of exactly what it says it is. We internalize something. So we tend to have lower self-esteem, depressive symptomatology, etc. Untreated prenatal depression is also associated with psychiatric disorders in adolescents, and that includes things like depression and anxiety. The study was published by Smith et al. She was one of my former grad students here at Brescia. And we also know with respect to linked lives that environmental stressors can interact with genetic vulnerabilities to produce disparities in health. So for example, the environment doesn't just mean what we think like climate. Environment can mean what happens in our own home. So I'll give you an example. If one, it's particularly more so for males, but if one has a genetic vulnerability to alcoholism, their odds of actually being diagnosed with an alcohol abuse disorder in adulthood skyrocket when that genetic vulnerability interacts with an environment such as not having enough food on the table because of poverty. So that what we call gene environment interaction is greater than the main effect of just genetics or just the main effect of poverty. When you have a gene environment interaction, it increases the likelihood of given specific health outcomes. Another key principle of the life course perspective is human agency. And sometimes I think it's definitely very important, but sometimes I think we give too much undue attention to it. So it's the idea that as humans, we can make choices in our life that set us off in a different trajectory, ideally a good trajectory in terms of improving health over the life course. But I would argue that while it's true individuals can make choices, sociocultural factors such as socioeconomic status, your gender, and your race limit the extent to which this agency can be activated. So rather than just saying, you know, make better choices, we need to look at what's going on in people's lives and these more, what I'll get to later, fundamental causes of health disparities, such as education or income, really impact the likelihood of you being able to make those right choices. So what is it about this socioeconomic status and health disparities? I mean, the fact that most of us on this call are highly educated, that doesn't just translate to better health, so much so that just having a higher income doesn't translate to better health, and vice versa. The fact that someone lives in poverty or that is lowly, that has poor levels of education, that doesn't just translate to bad health. There has to be something going on that drives that relationship between socioeconomic status and health disparities. And when we look at the literature, there's many factors, but there's two that just keep popping out paper after paper. It's stress exposure and risk-taking. So what we find is that for the most part, those who are low socioeconomic status, they tend to experience both more kinds and greater exposure to stress. And that could include things like poor living conditions, having an insecure job that's not stable, as well as financial difficulties, whether you have enough money at the end of the month to pay for the bills. We sometimes get a wrong perception of stress, and we'll say, you know, stereotypically, if they can just get their stress exposure under control and not be so vulnerable. But the reality is there's very little literature to support that. The reality is that most exposure is, most stress is related to exposure, not vulnerability, meaning that people from lower socioeconomic status are not more vulnerable, but they're just exposed to more kinds and greater exposure to stress. And the second real key factor that explains the relationship between socioeconomic status and health disparities is risk-taking. So for the most part, what we find are people with lower levels of education and income tend to engage in more risky health behaviors. So for instance, to keep with the idea of pregnancy, there's a lot of literature that supports that tobacco use and cannabis use is much more prevalent among pregnant women who have lower levels of education or income. And most of the literature supports this. And this is the kind of conceptual model that you'll see in the literature. And I would argue, unfortunately, it's also what granting agencies often look for. They'll look for these kind of conceptual models where you'll see socioeconomic status impacts stress, which in turn leads to disparities in health. Or socioeconomic status impacts risk-taking behavior, and this risk-taking behavior is the factor that then drives differences in health. So stress exposure and risk-taking are seen as mediators of the relationship, because you see they're in the middle. They mediate the relationship between socioeconomic status and health disparities. But the problem with these ideas of mediators, in my view, is that we're essentially blaming the victim. We're saying, hey, if you can just get your stress exposure under control, if you stop smoking cigarettes, stop drinking alcohol, start exercising better and eat better, you'll have the health disparities will attenuate. But this risk-taking behavior and the stress is not random. It's very much linked to what's going on in people's lives. So we're not addressing, in my view, the more fundamental causes of health disparities, which is things like race, which is things like socioeconomic status, gender, beneficial social connections, etc. So what does this mean in terms of policy? Well, in my view, it means that less focus should be put on behavioral change and more on socioeconomic status itself. So what you'll find, and I'm sure we've all read lots of papers that show this, is that whenever you see research that targets behavior change, trying to get people to change their eating habits or their exercise or their, decreasing smoking, whatever it might be, what we often find is it works for a while, but then life happens again. And when life happens again, what you often find, and this is why I'm a big fan of longitudinal research, is you'll see improvement, stabilize, back to normal. And this doesn't surprise me, because I believe that we're targeting the wrong things by targeting behavioral change. That if we really want to see population level change, not just an intervention for 30 people, we need to target the right things, and we need to target education, we need to target income. So let me give you an example. In Manitoba, Canada, this might surprise you, because a lot of times I'll get questions like, okay, I agree with what you're saying, but easier said than done. Let me give you an example to counter that. In Manitoba, Canada, what we found is that when you give income supplements to women who live in poverty during pregnancy, and we're not talking huge income supplements, equivalent of about $400 over the course of the entire pregnancy, the odds of preterm birth and low birth weight plummet. Now that's huge to me. They also increase the odds of breastfeeding initiation postnatally. So just as little as $400 in Canadian dollars given to a pregnant woman who lives in poverty can have massive long-term health implications for mom and baby. One of the most important papers I've ever read, it's an old one, goes back to 1995, Bruce Link and Joe Fallon. They wrote a paper called The Theory of Fundamental Social Causes, and it really drives a lot of the research that I do. And essentially what they argued was that socioeconomic status shapes exposure to individually based risk factors, such as diet and substance use. So let me give you some context here. When research shows that food price is the #1 determinant of food choice among those who live in poverty, how can we blame people for the choices they make in terms of what they buy at the grocery store when the cost of eating healthy foods is so expensive? So again, it's the finger pointing, eat better, but the cost of fresh produce today is getting astronomical. They also argue that when risk factors, or what we call mediators, like diet quality, physical activity, smoking, cannabis use, you name it, change, the differential exposure persists. In other words, the relationship between socioeconomic status and health disparities, or race and health disparities, or gender and health disparities persist. So they're arguing, so long as we target proximate causes of health disparities, we're not going to see big population level change. We need to target, if you would, the more fundamental social causes. Let me give you even more context to this kind of idea. So when we think of bad things that happen, okay, so we think of something like the Titanic. Who was it that died first? It was those that were low income. And we know why, because it was those people that were the last people to get on the boats. When we think of the tragic event of 9/11 and the World Trade Center, it was people with less prestigious jobs who were more likely to be in rooms without windows, and they were the ones who were more likely to die. And if we take a catastrophe like Hurricane Katrina, what we found is that it was the poor areas that were flooded first. In other words, it was those areas that had the highest risk of flooding. Alternatively, when good things happen, such as the discovery that smoking is harmful, what we found is that it's people who have higher levels of education that were more likely to take advantage of this information and to quit or reduce their smoking behavior. As someone who's heavily involved in foods and nutrition research, it's also interesting to me that when knowledge about health benefits of a low-fat diet came about in the mid-20th century, who was it that was most likely to take advantage and eat this way? It was people with higher levels of education. And likewise, when we think of new technology such as cancer screening, research shows that it's people with higher levels of education who are more likely to take advantage and get screened for cancer. A closely related concept to all this is that of cumulative disadvantage theory, proposed by Danifer in 1987. And it's still very much relevant in coming up on 2022. It's the idea that social disadvantage in early life can accumulate across the life course, leading to exacerbations in health disparities. So if you see this picture to the left, we see a situation where this is your son. It's been in the family for generations. And one family is passing on the riches, the other is passing on the poverty. Now, some of us would go, yeah, but I know people who grew up in extreme poverty that are now very highly educated, that have high levels of income, for sure. Both of my parents, neither one went to college or university. My dad finished grade 9 and my mom finished grade 12. So there's always those situations where that occurs. But the probabilistic nature, what I like to call of social science research, shows that for the most part, that isn't the case, that we see a very clear trend that shows that disadvantage or advantage accumulates throughout the life course. So if we take this back into the perspective of pregnancy, a closely related concept to cumulative disadvantage is the idea of exposure clustering. So let me give you an example. Children from low socioeconomic status are more likely to be born low birth weight. Research shows that. Okay, so being born small is not random in the population. It's very much associated with lower levels of education and income of pregnant women and their partner. These same children are more likely to be exposed to poor diets because there's a relationship between low income and diet quality. They're more likely to be exposed to secondhand smoke because we know that risk-taking behavior is higher among those who are disadvantaged. And they also have less opportunity to pursue post-secondary education. So if we look at this kind of schematic diagram below, this gives you another kind of idea of exposure clustering. So we see that adverse childhood experiences can lead to things like social, emotional, and cognitive impairment. When that kicks in, we know that in turn is correlated with adoption of healthy risk behaviors. This then could lead to things like disease, disability, and social problems, and ultimately to premature death. So what we see is a clustering of things in one's lives that lead to greater disadvantage. So let's link all of this kind of story that I told you of disadvantage with what is typically called DOHAD, Developmental Origins of Health and Disease. And I'm going to talk about someone named David Barker on the next slide. But basically, David Barker proposed that what happens here in pregnancy can influence, you can see here, all stages of the life course. So back when I was working full-time for pediatrics, our former chair, Dr. Guido Filler, gave a very interesting presentation that really piqued my interest in this area of research. He talked about someone named David Barker, and David Barker is an English physician and epidemiologist who created a hypothesis in 1990 that looked basically like this on the screen, that babies who are born small, so the examples I give here are preterm birth, low birth weight, intrauterine growth restriction, and small for gestational age. So babies born small have a much higher risk of, in adulthood, coronary heart disease, obesity, type 2 diabetes, and even mental health disorders such as depression. And in 2010, Time magazine came out with a cover story showing how the first 9 months shape the rest of your life. Okay, so basically the way the Barker hypothesis looks is like this. It takes the idea of what we call fetal growth programming. And essentially it argues that if the fetus is not well nourished in utero, and that can be under or over nutrition, it will program itself to deliver more nutrients to the brain than other organs of the body. So if we see down here, we have our early nutritional insults. This fetal programming leads to epigenetic changes, which then increase the odds of metabolic disorders, such as diabetes or obesity, for example. I'm a statistician, so I'm always a little bit skeptical of causal relationships. So I would argue from a statistical standpoint that we know the correlation between birth weight and adult disease exists, but that doesn't necessarily imply the relationship is causal. Why do I think it's not just causal? Well, we know that adverse birth outcomes such as preterm birth, low birth weight, intrauterine growth restriction, small for gestational age, these birth outcomes are very much factors that are influenced by socioeconomic status. In other words, these birth outcomes are not random in the population. They're linked to parental socioeconomic status. So if you kind of look at this conceptual model here, we see a whole bunch of things going on. So if we just look here, this is essentially the Barker hypothesis, that babies born small have higher risk of adult disease. But conceptually, we know that these birth outcomes are very much linked to parental socioeconomic status. We also know that parental socioeconomic status is highly related to diet quality during pregnancy. These factors of diet quality are very much also linked to birth outcomes. Diet quality is also linked to SES and adulthood. So this is just a conceptual model of a chain of things that basically bring a new level of complexity than just looking at what we would call kind of bivariate relationships. And I haven't even brought in genetics here either. So the point I'm trying to make is that the Barker hypothesis may be a physiological process, but it's likely also patterned by social structure, for example, socioeconomic status. So to say all this, one of the issues with a lot of this research is that you see a lot of finger pointing. such that mothers are seen as causal agents in the reproduction of adult disease. In other words, causal factors are maternal choices, and mothers are seen as either harmers or helpers in the reproduction of adult disease. I like this quote by Winnett et al. In 2016. They maintain that, quote, "A frame of behavior that rests solely on the individual and avoids broader context is generally easier to communicate than one that draws connections to external forces." In other words, graining agencies, it's much easier to target proximate causes like diet, like physical activity, like smoking, like cannabis use, like alcohol use, than to target the more structural factors that are operating in many of these women's lives. So one of my former graduate students, Emily Campbell, former graduate student here in our Master's Foods and Nutrition program at Brescia, published a very nice paper at the very, very beginning of 2018, January 2018, came out just before online. And we looked at the relationship between socioeconomic status and adverse birth outcomes right here in Southwestern Ontario. Interestingly enough, I applied for a grant for this. I didn't get it. And I was told at the time that the relationship is so obvious. Of course, there's nothing really novel. There's, of course, a relationship exists between socioeconomic status and adverse birth outcomes. So what we did is we looked at every single pregnant woman and their subsequent birth outcome between 2009 and 2014 at London Health Sciences Centre. So we had over 26,000 pregnant women, quite a bit. If you know how LHSC works, they don't typically ask questions pertaining to education, income, occupation of pregnant women. But we did have the maternal postal codes. So with the help of the Human Environments Analysis Laboratory, which I'm part of, which is HEAL at Western University, and using GIS software, we geographically mapped 26,000 plus pregnant women to the precise area that they were living in terms of their dissemination area or neighborhood, which is the lowest level that StatsCan releases income data for. And interestingly enough, we didn't find that socioeconomic status had much of a relationship with birth outcomes. We found a very small relationship with maternal education in the right direction that we would presume. Lower levels of education correlated with lower birth weight, but the relationship was very small. But what really did matter was risk-taking behavior. And one of the interesting findings from this study was that we found that pregnant women who reported using cannabis throughout their pregnancy had almost a 3-fold increase in low birth weight. So 2.7 times greater odds. And the really interesting thing about this finding is that we were able to statistically adjust for tobacco smoking. So I have to say this, when I see studies that look at cannabis and birth outcomes, but they don't have data on cigarette or tobacco smoking, I'm very skeptical, because we know that tobacco is highly associated with small babies. But we were able to adjust for that. And even after doing that, we found a strong relationship between marijuana use during pregnancy and birth outcomes. And at the time, it was the largest study in Canada to find that relationship. Saying this humbly, but it is kind of interesting. We did get a lot of media attention for this. It was on CTV News, various newspapers across the country. My daughter Morgan called me when I was at my other daughter Madison's soccer saying, "Dad, really cool, you're on BuzzFeed on Snapchat." I said, "Honey, I don't know what that means." So now I'm learning more about BuzzFeed, I suppose. But she said it was very widely disseminated, and it was named the top medical discovery of 2017 at Lawson. It came out in December online before it was officially published in January. So it definitely got a lot of media coverage. The next step that we wanted to look at is, let's take this a step further. Let's look at alcohol outlet accessibility and adverse birth outcomes. So there's a lot of literature that shows that the greater the alcohol outlet accessibility in terms of where you live, the higher the alcohol consumption. So there's nothing really new there. But we haven't really studied that relationship among pregnant women. In fact, this was the first Canadian study to examine that, the impact of the built environment, if you would, on alcohol consumption during pregnancy. And what we found, at least here in Southwestern Ontario, was that greater alcohol accessibility around pregnant women's homes, and that means both proximity to alcohol outlets, whether that be LCBO, beer stores, wine stores, you name it, greater proximity and density increased alcohol consumption among pregnant women. It did not translate into poorer birth outcomes, but there was an interesting finding that came out of this research, and it's an unfortunate one. And that was that across Southwestern Ontario, alcohol outlets tended to be clustered in areas of greater socioeconomic disadvantage, which is not a good thing, because we already know from earlier in the slides that risk-taking behavior is more prevalent among people who are disadvantaged. So what we're finding is, and I know we know, well, LCBOs are everywhere, very much true, but overall, alcohol outlets tend to be clustered in areas of poor income areas. The next step then was to take this a step further. Nick Woods, tremendous guy. Nick Woods, I've known for a long time now. He was my master's student here at Brescia in food and nutritional sciences. And I went on to supervise him for his master's here. He then did a master's in epidemiology at Western that I supervised him in. And now I'm supervising him in the PhD program in health promotion in the Faculty of Health and Rehab Sciences at Western. So Nick, back when he was in his MSCFN here at Brescia, did a fantastic review looking at the influence of the built environment on adverse birth outcomes. So we wanted to take the alcohol outlet accessibility a step further. And essentially what he found was that there are 9 key built environment factors you see in the literature that test the association, if you would, with adverse birth outcomes. And those included roadways, greenness, because we know greenness is related to better mental health, parks, proximity to trees, etc. Power plants, gas stations, waste management, power lines, neighborhood conditions, food environment, and industry. But the most common built environment variable study in the literature were roadways. And basically what he found was that 71% of studies found a statistically significant small to moderate correlation between high traffic exposure and adverse birth outcomes. So that got me really excited, not about the outcome, but about, okay, these are factors we need to now consider in an actual quantitative empirical study. So with the help of my close friend, Dr. Jason Gilliland Heel, and Ali Smith, who was also my grad student here at Brescia, we then took Nick's review paper and actually assessed the relationship between environmental factors on birth outcomes here in Southwestern Ontario. And the objective of the study was to test the relative influence of environmental, demographic, medical, behavioral, and neighborhood socioeconomic status factors associated with low birth weight and preterm birth. I should say this, that most studies only look at the impact of environment on birth outcomes or socioeconomic status on adverse birth outcomes. Very few look at the impact of both. So we tried to capture that. So we looked at the impact of sulfur dioxide, ground level, ozone, fine particulates, where pregnant women live in terms of their distance, in terms of proximity to major highways or roads, gas stations, power lines, industrial land use, distance to parks, which we know is improves a greater accessibility in terms of walking, etc., and opportunity to walk through parks, grocery stores, variety stores. And the findings were really, really fascinating. So we found that for low birth weight, sulfur dioxide exposure was highly associated with low birth weight. The odds ratio was 3.4. In other words, for a 1 unit increase in sulfur dioxide exposure, you are about 3.4 times the odds of having a low birth weight after statistically adjusting for all other variables in the model. Now, when I went to publish this was published in a pretty solid journal, Environmental Research. They said, okay, but a 1 unit increase in sulfur dioxide is a lot. So what happens if you just do a small incremental increase? And what I did is I scaled back that sulfur dioxide exposure variable to what we call an interquartile range increase, a small increase that were very common, for example, in our data. And we found that an interquartile range increase in exposure to sulfur dioxide was associated with about a 30% greater increase in low birth weight, even after adjusting for all other variables in the model. And then we wanted to look at preterm birth, and a lot of the same. So we found that a 1 unit increase in sulfur dioxide exposure doubled the odds of a preterm birth. And when I scaled back that variable for a small incremental increase in terms of an interquartile range increase, pregnant women were about 1.2 times more likely to have a premature birth, adjusting for all their variables in the model. And I will say this, some of you might be thinking, oh, I thought the air quality was really, really good in Southwestern Ontario. For the most part, it is. But what happens is we modeled exposure in terms of a 3-year average trend. And what we found was there were spikes, if you would, on specific days. And those spikes, they were everywhere in Southwestern Ontario, but they did tend to be clustered in hotspots like around the Michigan border, like Sarnia or Windsor. And it was interesting because when this got published, I got a call here at Brescia immediately from Windsor, and we didn't even mention Windsor in our paper, saying we'd like to interview you about our study. Just them knowing that their exposure to air pollution is quite high around the border. So other variables that were positively correlated with preterm birth were low immigration prevalence, underweight pre-pregnancy BMI, having had a previous preterm birth, and anxiety during pregnancy. And the immigration thing might surprise you, but essentially what we found there was recent immigration was associated with a decreased odds of a preterm birth or a low birth weight baby. And that's actually in line with some other studies, not a lot of studies on this topic. And it's the healthy immigrant effect, migrant effect, the idea that when they first come to Canada, they tend to be healthier. And when it's been recent immigration, they have a lower odds of an adverse birth outcome. But the longer they've been here, they tend to be more accustomed, if you would, to our Canadian lifestyle. And then the disparities tend to attenuate and they become more similar to our Canadian citizens. So taken together, these results suggest that pollutants can travel from the lungs of a pregnant woman to the placenta. And the last kind of study I'll show you is that is a recent systematic review and meta-analysis I did with one of my former graduate students, looking at the prevalence of low birth weight, premature birth, and stillbirth among pregnant adolescents in Canada. I truly believe that teenage pregnancy is a forgotten social issue in Canada. It tends not to get reported very much because I feel like we feel that we have it all under control, but we don't. Another study I'm not going to talk about today, but at London Health Sciences Center that I did, 4% of all pregnancies were teen pregnancies. That's quite high. And one could argue that, you know, LHSC is a tertiary institution that look at higher risk pregnancies for sure. So that might be a little bit on the higher side compared to other institutions, but nonetheless, it's still a very, very important issue, and is becoming more so as mental health problems escalate. Basically, what we found in this systematic review meta-analysis of all studies in Canada was that compared to adult moms, adolescent mothers had a 56% increase in the prevalence of low birth weight, a 23% increase in the prevalence of preterm birth, and 20% increase in stillbirth compared to adult moms. And one of the things that I'm proposing moving forward is we need to go, okay, this is an interesting bivariate relationship in Canada. We need to investigate more the mechanisms surrounding these differences in maternal age.